The labor process consists of 5 factors: passenger, passageway, process of labor, powers, and physiological factors. We're going to discuss the passenger, which is the baby. And here we have to adjust the factors of the baby's head size, its lie, its attitude, its presentation, and position. So with its fetal head size, we have to decide how big the head is in relation to the pelvis, the posterior, anterior fontanelles. We want to feel for that. That's one of our nursing interventions while we're doing an assessment. In which direction do we think the head is coming? And we assess that by the fontanelles. We're going to assess the molding. So if it's caput, asynclitic birth. Caput is when we're going to have serosanguinous fluid in the baby's head, so it's going to cause swelling, and that's usually due to a vaginal birth. It is completely normal. It's common to be seen in vaginal births, and it does correct itself within the first few days after delivery. And then an asynclitic birth is when the baby comes out at an angle, so it has that serosanguinous fluid. It's just disproportionate. It's not even around the fontanelles. It might be on the left side versus the right, or vice versa. So then we'll talk about the fetal lie. So this is the relationship between the long axis of the spine of the mother and the baby. So you want it to be longitudinal. You want the mom and the baby spines to be parallel with each other, not perpendicular. If it's perpendicular, we call that transverse. And you can also have longitudinal lie breech, which is when the baby is not coming out head first versus it's coming out bottom first. So it can be the feet are coming out, it's bum, one foot. It just depends on what type of breech they're in. Now we have fetal attitude. How is the baby holding its own position? We want the babies to be flexed with good muscle tone. A flaccid baby is a very bad sign. It's indicative of a possible central nervous system problem. So if the baby can't hold itself together, this is a very, very bad sign, and we need to get help. Next, we have fetal presentation. So what part of the baby is entering the pelvis first? We want the baby to be coming head down. That's optimal birthing position. But sometimes we can have a breeched baby where it's coming bottom first. So in this case, we can have a complete breech, which is when the baby's it has its legs crossed together. It can be incomplete breech, where one leg is down and the other one is up towards its head. Frank breech, where both feet are up towards the head. Now we can also have a shoulder presentation where the baby is in transverse lie possibly, so its shoulder is coming out first, and this can cause shoulder dystocia. And we can have face presentation where instead of the baby having its chin down towards its chest, its head is looking up towards the sky, and it can cause the face to come out before the occiput, the back of its head. If we see the baby is not in the right position, we can do an external version where we try to move the baby from outside of the mom's tummy. Next, we have the fetal position, the relationship between the presenting part of the 4 quadrants of the maternal pelvis. And so we do this based on a 3-letter system. So the first letter is going to indicate the presenting part on the left or right side of the maternal pelvis. And then the second letter is going to be the presenting part. So if it's the occiput, we put O. The third letter is the position of the presenting part in relation to the mother. So is it anterior, is it posterior, is it transverse? So optimal birthing position is going to be direct OA, direct occiput anterior. So occiput is going to be the back of the baby's head, and anterior is the position the baby is in relation to the mother. Now we'll discuss the powers of labor. So this consists of primary powers, which are uterine contractions, and secondary powers, which are the pushing. So the uterine contractions are categorized by frequency, duration, and intensity. The frequency is how often they occur, the duration is how long they last, and intensity is how hard they are. So a good nursing intervention to assess the intensity of a uterine contraction is to actually palpate the stomach during a contraction. And the way you know, a good trick to know, is for a mild contraction, the stomach should be about as firm as touching the tip of your nose. So not very firm, pretty flimsy. A moderate contraction would be like touching your chin, and a stiff contraction would be like touching your forehead. So this is a good nursing intervention to assess the intensity of a contraction. Now you're also going to be assessing dilation and effacement. Dilation is how dilated, how spread out the cervix is, and it's between 0 centimeters to 10 centimeters. And effacement is how thin the cervix gets. So you do this by percentage. So 0% effaced means it has not stretched yet. 50% effaced and 100% effaced. 100% effaced is when it's super, super thin, almost paper thin, and 50 is halfway there. So then you're going to assess the fetal station. Now this is where the presenting part of the fetus is in relation to the ischial spines. So if it is above the ischial spines, this is going to be -2, -3 station, just depending on where the head is, and the head is still floating in this case. Now if the head is in line with the ischial spines, we consider this 0 station. This means the head is engaged and it is getting ready for labor. When we do these assessments, it's going to be during our vaginal exam. So we are going to assess dilation, effacement, station, all during our vaginal exam. So its secondary power is the pushing. The pushing can be categorized into open versus closed glottis. This means the mom is screaming or the mom is not screaming. Now we do find that closed glottis tends to be a little more effective because it does cause stronger pushes. Now we also want to position the mom in a way that eases labor as much as possible. So this is allowing gravity to help. And we want to change the position frequently to not to tire the mom. Now onto the process of labor. This is going to incorporate all of the 5 P's. Now, when a woman comes in who believes she is in labor, there are some common signs we tend to find as impending signs of labor. These are lightening, increased urination, a small weight loss, Braxton Hicks, surge of energy, and vaginal secretions. Now, some of the reasons we might cause labor are a variety of things, and there's no definite answer. But things that we have noticed are a trend are an increase in fetal hormones, uterine distension. So a mother who's carrying twins might go into labor earlier than a mother carrying one baby because her uterus is stretched out thinner, faster than the other mother. Placental aging. So let's say the mom is 41 weeks pregnant. The placenta is now, it seems to have its own time frame where it only will work sufficiently for a certain amount of time, so this is placental aging. Decreased progesterone, so progestation hormone. This is the hormone that allows you to stay pregnant, so decrease in this. Fetal fibronectin, increased estrogen and prostaglandins. Now onto mechanisms of labor: engagement, descent, flexion, internal rotation, extension, external rotation, expulsion. Now we're going to discuss the difference between true and false labor. The biggest indicator between true and false labor are not the contractions themselves, but actual change in the cervix. So we want to see dilation and effacement. You do want to assess the contractions. You want them to be regular and increasing in intensity. However, with false labor, the contractions are irregular. There's no change in the cervix. You might have Braxton Hicks, but at the end of the day, if there's no change in the cervix, we know it's not true labor. Now, the stages of labor consist of 4 stages with periodic phases in between. So with stage 1 of labor, this is going to end with complete dilation. We're going to have, it starts with the latent or early phase, where the cervix dilates up to 3 centimeters. Short and irregular contractions, water may or may not be broken at this point. The cervix is beginning to soften and efface. The mom is excited and talkative. This is a great teaching opportunity for the nurse. The active phase, which is also falling under the first stage of labor, is going to have contractions that are 3 to 5 minutes apart. The cervix is 4 to 7 centimeters dilated. The mom is more focused and she considers more pain control options at this point. The transition phase is when the contractions are getting closer and stronger and may have double peaks. The cervix is 8 to 10 centimeters, complete effacement, and this is the shortest phase of labor. Next, we go on to stage 2 of labor. This is going to end with the birth of the baby. So in stage 2, we have the latent phase, which is also the physiological lull. The contractions space out slightly from 5 to 30 minutes apart. There's a brief rest after the transition phase, and we prepare for descent. Now, descent is the next one. The descent phase, we're going to see the Ferguson's reflex. This is when the baby's head stretches the cervix and feedback is sent back to the brain, where oxytocin is released to stimulate stronger uterine contractions, pushing the baby down. The transition phase is where the expulsive contraction. The baby descends in real crowning and the ring of fire is occurring. And then we have stage 3, which ends with the expulsion of the placenta. The contractions are less intense, which is a sign of separation. There's some cramping. At this point, we do want to administer Pitocin to increase uterine contractions to bring it down to normal size and expel the placenta. Now we have the final stage, stage 4, which is the recovery. This is about 2 to 4 hours after birth. We want to check the fundus every 5 minutes, 3 times, then every 15 minutes. We want to assess the vitals and address comfort measures with the mom. Next, we're going to discuss the passageway, which consists of the birth canal. So the birth canal is the bony pelvis, the soft tissue, which is the cervix, vagina, and pelvic floor. So in the passageway, we want to make sure the mom has a perfect pelvis. If she doesn't, other considerations will be taken. So the perfect pelvis consists of a hollowed sacrum, a movable coccyx, a blunt ischial spine, and a wide pubic arch greater than 90 degrees. Now the perfect pelvis is called a gynecoid pelvis. Physiological factors that affect labor include coping mechanisms and cultural considerations. With coping mechanisms, this is a very, very stressful time for the mother, so you want to make sure she's comfortable, because there are some mothers who might not even want to start pushing until they are in a comfortable position. For instance, if the husband is not in the room, the grandmother is not in the room, the mom might not want to start pushing, and we need to talk her through this. We also want to assess cultural considerations. So let's say the mother doesn't speak English, we want to have a translator in the room so she knows what's going on. If the mother is from a background that doesn't allow men to be in the room during this process, we want to respect that as well and try to get female nurses and female physicians in the room.